Hello everyone, I'm Ahmed Professor of Vascular Surgery in Cairo University, and I'm happy today to have Bruno Meigliara, consultant of vascular surgery from Italy. I'm really happy to have him again in Cairo. Welcome again, Bruno. It's always a pleasure to see you here in Cairo.
Thank you. It's a really pleasure for me to be here these days in Cairo for the EVS 2024, and I'm really happy for this possibility to have this podcast today.
Okay. We have been seeing lots of presentations and talks about very complex cases in the tibial disease. And we have seen so many advances by you and other colleagues regarding this field of vascular surgery. But I would like to imagine something with you. Imagine that I'm a newly graduated vascular surgeon. I'm a new trainee in my first months of training. I've heard from my senior vascular surgeons that there has been one option for treatment of those with very bad limbs, named arterialization of the vein. Some of them already have made surgical procedures to do this in the past, maybe over 25 or 30 years, but they believe it wasn't good enough and it couldn't salvage their limbs, and they stopped doing it. And now I'm attending this meeting here and seeing your presentations and other colleagues from Italy, Spain, talking again about deep venous arterialization, but this time it's an endovascular route. What has changed? Why did we change our beliefs, and what is the concept behind this, and what did it bring it again back to our practice?
Okay, well, fantastic question, this complex question, because of course the first thing when I speaking with a young trainer, I want to stress that the first thing is to try to open the arteries, okay? Because the arterial revascularization is our goal in all our endovascular treatment. Of course, there are some patients, I think around 10% of our patients that are really no option patients. So no option to realize an arterial vascularization, an effective arterial revascularization is quite difficult to define right now the no option patient. The definition is considered arbitrary, but this patient, there aren't this patient in our clinical practice. So for this patient, the option in the past was the major amputation. We know that there are some meta-analyses showing that in case of no treatment of this patient or standard care for this patient, the amputation-free survival at 1 year is around 30%, so really dramatic situation. And so we tried to find something different, something to treat this patient. And we know that the arterialization, the concept of the arterialization is really old, because the first publication is in 1912 by Alsted. 42 patients treated with arterialization, all amputated. The biggest problem of the arterialization, surgical arterialization, is how to treat the vein into the foot, because to connect the vein with the artery is not a big problem. But how to treat the vein into the foot surgically? This is the biggest limitation, because the vein has valves, into the foot, and so we have to destroy this valve. And at the end of the 70s, at the beginning of the 80s, some authors, the most important was Francisco Lengua, considering some different devices, surgical procedure to destroy these valves, but the procedure was really difficult with not really good result. I think everything changed in 2010, 2012 with the introduction of the concept of the hybrid approach. So to do a surgical AV connection and then to go into the foot endovascular with endovascular technique, so with a catheter, with guide wire to cross the valve and to try to crash the valve. So this is the first step at the around 2010, 2012, and so we shift a bit the idea about the effectiveness of the arterialization.
But was it at that time quite effective and successful, or was it just a step until you reached the final approach?
No, in 10, 12 years ago, but also now we are at the beginning of this procedure. There are a lot of issues to try to solve. But the result of the surgical approach changed with a better result. And so based on this, the first one was a vascular surgeon from Singapore, Stephen Coombe, and I followed the idea of Stephen in 2012 to try to do a totally percutaneous arterialization. This because these patients are really fragile. So every surgical incision, every trauma into the leg is a drama for this patient.
We always tell our trainees that if someone has his vessels diseased up to the foot, this means that the whole arterial system, including the heart, is already diseased by that time. So most probably he's a cardiac patient and with cerebral insult.
Yeah, this is the problem of this patient, because are the worst patient that we treat. So to do a mini-invasive treatment, in my opinion, is the best choice for this patient. So this is, we started in 2012 to do a really prehistoric procedure, trying to connect percutaneously the proximal tibial artery with the satellite vein, with a catheter, a CTO guide wire, but the success was around 20%. In 2017, the Pioneer Plus catheter, so the anivus guided reentry catheter by Philips, came back on the market, and so I thought, if I go with an IVUS device into the tibial, I can see the satellite vein around the artery, and so I can puncture with the needle from the artery into the vein.
Under guidance of the IVUS.
Yes, this was my first idea. In the same time, appeared on the market, or better, appeared for the initial study, the lymph flow system, that is the most studied device to create the arterialization. But at the beginning, the lymph flow system was completely different than now to do the connection. In the lymph flow system, there were two ultrasound catheters that one place from the artery, the other one place from the vein, that are able to recognize, and then we push the needle from the artery into the vein. And was not so easy to connect the artery and the vein like this, and so now they change completely. They put now a basket from the vein, the distal vein, and the needle from the proximal artery. Now is,
but still, it has an ultrasound from the arterial side.
Yeah. So the problem, in my opinion, is that all other techniques to create the arterialization need a proximal puncture from the common femoral, distal puncture into the foot venous system. With the Piper technique, it's possible to realize all the procedure just using one antegrade access from the artery, so avoiding a puncture into the foot. This is an infected
using the pioneer IVUS ultrasound
because
catheter.
with the IVUS it's possible to find the vein and then to work just from the proximal axis. And this is, in my opinion, the biggest advantage because we avoid this puncture into the foot. Usually it is a really damaged foot with a big lesion, eventually with infection. And to put a guide wire in this area, in my opinion, is not a good idea. And after on this guide wire to put a covered stent. So this is an advantage. I didn't find in the paper of the lymph flow if there were infection of the covered stent, but I don't know. It's not. This is not a problem. So now we have some different technique to create the AV connection, because the first problem when we do the percutaneous arterialization is to connect percutaneously the artery and the vein. So we can use the lymph node, okay, but now it's not available in Europe. In Egypt, it's available just in US. Of course, is the well-studied system. All the most important paper published right now are about the lymph flow. Okay, so I'm not here to compare the Piper, the VAST, the other technique with the lymph flow. But we can try to standardize better also the other technique. And during the last 5 years, I work a lot on the Piper technique to try to standardize well this technique. So now in this technique, we start with the Pioneer Plus. We do in every patient a connection in the proximal portion of the tibial. So usually I prefer to go in the proximal 3 centimeters of the posterior tibial artery. In some cases, I do the connection at the tibioperoneal trunk. It's impossible to work on the anterior tibial artery because the circulation into the foot around the anterior tibial artery is not well developed. So to go into the foot percutaneously, the only way is to go through the deep plantar venous system.
So it's not for everyone.
No.
I mean, you have to stick a little bit to the tibioperoneal trunk or the posterior tibia.
Yeah, this is the only limitation of the totally percutaneous, because of course, if the circulation into the foot is sustained by the posterior circulation damage, but the only artery that arrives into the foot is the posterior. To place a covered stent into the posteriors is a drama because we close the posterior tibial, and we know that the arterialization needs at least 4-6 weeks for maturation and to work. So we induce an ischemia into the foot. So this is the only situation where I prefer the hybrid approach, so to connect surgically the great saphenous vein or the posterior tibial vein with the arterial system, because in this way we respect the arterial circulation. Anyway, about the totally percutaneous, of course, we have to know well also the anatomy of the venous system, because the anatomy of the venous system is more complex than the anatomy of the arteries. Yeah. The first time that I arrived into the venous plantar, into the foot venous system, I inject the contrast. The first thing is that there are valves that stop the contrast, so until you are not able to cross the valves, it's impossible to see
I find
anything.
severe difficulty to understand actually what I'm seeing.
So we have to work without the guidance, but to think, this is the vein, okay, I try to cross. And the other thing is, when you arrive into the forefoot, inject the contrast, there are a lot of vein into the foot, because anatomically there are 4 different levels instead of 2 levels of arteries. But the most important level that we can use for the arterialization is the deep plantar venous system, because this is the system that through the lateral plantar and the medial plantar vein, 2 veins for every arteries, allows the drainage then through the posterior tibial vein. So if we connect the posterior tibial artery with the posterior tibial vein, we obtain we reverse the flow. We obtain the flow through this system into the foot. So after the connection, it's really important to cross all competent valves. And then after crossing and arriving with the guide wire into the foot, we have also to try to obtain some flow in the direction of the forefoot, because the first problem is to obtain a flow, but seems to be in a roundabout. The flow comes with the deep plantar venous system and
gets back through the veins to the
through
venous circulation.
yes. So we have to try to obtain something in the direction of the forefoot, and so to also to try to crash a bit the valves into the metatarsal vein, and the most important is the dorsal main vein of the first 2. This is the way out of our foot.
So to summarize, the basic principle is first creation of an opening between an artery and vein, very distal as much as we can, preferably in posterior tibial artery or tibial trunk. Once we established a connection between of them, we have to secure this by a covered stent. Maybe this would be the last step, but
usually before to put the covered stent, we cross all competent valves.
At the end, this will be secured by a covered stent. All valves have to be destroyed, whether by balloon dilatation or maybe after insertion of covered stents at the end, to make the flow directed downwards instead of escaping back from the collaterals to the heart. And then you choose specific plantar veins, which you believe, based on your knowledge of the anatomy, that these will supply best the foot. So you complete your dilatation of these veins to destroy their veins and make sure that the flow really goes into these toes or metatarsal part. Is that in a simple way what you are going to do?
Yes, this is the concept, to destroy the valve, to obtain a bit of flow in the direction of the forefoot. Then usually it needs weeks. Then during this period, the arterial flow into venous system destroy completely the valves, and so this is the next step to obtain a very good maturation of our arterialization. Of course, to direct the flow downward, it's mandatory to put a covered stent. A covered stent in all the technique outside the lymph flow used is the Viaband, because the Viaband, I think, is the best stent for this area. No radial force, we have to work in a vein, so no compression, external compression, and at the connection point between the artery and the vein, usually I prefer to put a coronary covered stent, or a coronary big graft or a papyrus from Biotronic, and a 3.5 millimeter, and flaring the venous part, just to obtain a tapered stent from the artery into the vein. then along a 5 millimeter wire band. And usually now with the wire band, I arrive till the foot, till the common plantar vein, crossing at the ankle level the calcaneus channel, because the calcaneus channel is a really narrow area, fibrotic area, and usually the flow drops significantly down in this area. This is the area where there is the higher risk of restenosis, of reocclusion. This is the reason now why now I go directly into the foot. So after placing the cover stand, the procedure is completed, okay? But started what happened after the arterialization, because the problem, yes, is to create this new circuit, this new flow, arterial flow through the venous system, but now during the first weeks there is the worst situation for the patient, for the surgeon, because usually there is some different degrees of cyanosis, of edema, extension of the necrosis, more pain, higher risk of infection. This is the storm after the arterialization, due to the one thing, due to the ischemia that we induce into the foot, because there is a stealing of blood through the venous system from the artery. So from an high resistance system to a low resistance system. And the other end, there is a fight between the vein and the artery at the capillary level. So till the flow into the venous system is able to win the flow into the arterial, and then to reverse the flow into the capillaries, this is a very difficult period for the patient.
I think these few weeks are very challenging. Probably the patient and the surgeon will pray until they reach this.
Yeah, we have to discuss very well with the patient.
Any infection flaring at that time will mean an unfortunate early amputation decision, because I can't wait for sepsis.
No, this is a big problem, because we try to avoid any surgical procedure into the foot during this period. So during these weeks, there is this the mechanical theory proposed by Lengua. So when the pressure into the venous system is higher than 40 millimeters of mercury, this allows to fill up the capillaries in retrograde, and then progressively to open the hibernatic artery into the foot. This is the mechanical theory that allows to understand why a vein is able to give nutrition, to give oxygen into the foot. This reverse of the flow into the capillaries, but this takes time, and so this is a really, really strong period for both, for the surgeon, above all for the patient. But after this phase, usually started the healing phase with the appearance of a new tissue, new granulation into the foot, and so we can start with the foot surgery. Another really important step is to realize a foot surgery in the right way, because at the beginning we did a foot surgery like after an arterial revascularization with suture. We did a TMA with a primary suture, but the venous system is more superficial than the arterial system. So we try now to avoid every type of suture, just an open TMA, and then dermal substitute, skin, autologous
Any compression
skin,
will ruin everything.
Any compression, just to, and so this is the reason why the in my pilot study, the healing time is the median healing time is higher than 200 days, so longer than after an arterial revascularization. And the healing started is more evident between 6 and 12 months after the arterialization. This is a really important concept. So to do the we say the tension-free surgery without tension, without suture. This is another really key point to obtain the healing in this patient.
But still looks very promising, especially for those kind of patients in particular. And I really admire the alternatives of line flow you are using and the other colleagues, because this will make us in Egypt consider it. We are looking for a little bit cheaper solutions, and even as Marta Lobata said, making it at a lower level may lead to even the use of less tools. So I believe this is something to start with in Egypt here as well, and we will follow your results and your subsequent publications to see how it goes on. So I'm really happy with this information, and I hope that everyone can understand now the basic principle of this technique, and maybe salvage more and more patients. Bruno, thank you again. Thank you for being with us again in Cairo, and thank you for the podcast. And I always wish to see you, whether here or anywhere in the world.
Thank you to you. A fantastic opportunity for me to discuss about the arterialization to be in Cairo. Thank you.
Thank you.